So, thunderclap headache is what reaches is 7 out of 10 intensity in less than a minute. It is associated there are many causes of thunderclap headache as noted here. They are mostly hemorrhage, vascular, and some other kinky causes. So, hemorrhage is your subarachnoid hemorrhage, your sentinel subarachnoid hemorrhage, and ICH. Your sentinel or a warning bleed is a minor blood leakage from an unstable aneurysm. So means that there is an aneurysm which has given up a little bit and the vessels have contracted and sealed it, but it can rupture anytime. So vascular causes are your SAH, sentinel bleed, and ICH. Then there are vascular causes which are your venous thrombosis, venous ischemia, dissection, and PRESS, posterior reversible encephalopathy syndrome. PRESS is your basically hypertension and vasogenic edema in the posterior brain, causing headache, seizure, confusion, and vision loss because the posterior brain edema is there. As you can see on this MRI, we see more white in the posterior region, and on the CT it's more black on the posterior lesion. You see a side by side comparison of the CT and MR. The hypertension causing edema of the posterior aspect, causing visual disturbances and PCA like vertigo, seizures, headache. The other causes are your coital headache, Valsalva, SA, spontaneous intracranial hypotension, hydrocephalus, pituitary hemorrhage, and glaucoma, causing thunderclap headache. Coital Valsalva, SIH, pituitary bleed, and glaucoma. What are the red flag signs of headache? You can remember it by a mnemonic SNOOP. So S for 2 times and NOP. S is for sign and symptoms suggestive of a secondary pathology like systemic signs and symptoms, fever, and some other systemic signs and symptoms. So systemic symptom, your fever, lethargy, vomiting. Vomiting shows raised ICP. Then secondary risk factor, immunodeficiency, obese, drugs, known risk factor for intracranial pathology like old age. Then neurological sign of symptom, nuchal rigidity, onset, sudden onset, awakening from sleep after a trauma. Then headache causing personality change, postural aggravation. Personality change shows your frontal lobe is involved. Postural aggravation shows your ICP is like there is some CSF leak. That's why when you get up, the headache worsens, and when you lay down, the headache stops. So involving the frontal lobe, CSF leak. Then progressively worsening in severity. It implies that the bleed is worsening. Then precipitated by Valsalva. Precipitated by Valsalva indicates your venous headache or a Chiari malformation headache. Then there is pulsatile tinnitus. Pulsatile tinnitus, it is seen in arterial malformation or venous sinus thrombosis like carotid stenosis, atherosclerosis. Then there is papilledema. Papilledema means raised ICP. If we come to tendinalis, onset, like it goes from the history to the exam. Onset, if it is sudden onset associated with trauma or exertion, it is a serious headache. Symptoms including anything other than headache like some focal weakness, altered mental status, seizure, fever, neurologic symptom, visual changes. Then, if a person is taking medications, especially causing bleed in your brain, anticoagulants, antiplatelets, recent antibiotic use, immunosuppressants. Recent antibiotic use is important because it may hide your meningitis, partially treated meningitis, and immunosuppressants can lead to brain abscess and they can also hide the inflammation in your brain. Past history, there is no prior headache, so why has the headache popped up suddenly? There's something must have changed. Change in the headache quality or increased severity. Then associated systemic complaints like pregnancy, SLE, Behçet's, vasculitis, sarcoidosis, cancer. Repeat after me. Pregnancy, SLE, Behçet's, vasculitis, sarcoidosis, cancer. Then physical exam, you see altered mental status, fever, neck rigidity, papilledema, focal deficits. These are not just headache, they are indicating something much deeper harboring as headache. The headache quality, change in the pattern, frequency, intensity is also a matter of concern. Next is fever. Fever is a separate topic in itself. It raises concern for CNS infection like meningitis, encephalitis, brain abscess. But the absence of fever does not exclude infection, especially in patients of extreme of age and immunocompromise. Headaches in patients with HIV and CD4 less than 200 have a high risk of intracranial pathology. What are the clinical features suggestive of headache? So, prior history of migraine, young person, multiple prior episode, aura and prodrome. Aura is visual or audible stimulus which indicates that headache is about to occur. Then family history, some familiar triggers. It could be your menstruation, your going in the sun, certain like sleep pattern, dehydration, skipping meals, bright light, weather changes, cheese, coffee, alcohol, artificial sweeteners. All these can trigger headache and they vary patient to patient. Then history of motion sickness is also suggestive of migraine, especially in a cold AC car without any ventilation in the bright sun and you're eating a wafer bar. Never mind. So features of migraine are called as pound. It is a pulsatile, 1 day onset, unilateral, nausea is present and disabling in nature. The patient cannot continue his or her own work. They want to just take a rest and sleep. Chronic use of analgesic and anti-inflammatory agents may result in rebound or withdrawal headaches. So don't eat Dolo like a candy. Medication overuse headache is defined as use of more than 10 times a month and is notable for ergots, triptans and opioids. So do not use your sumatriptan, your ergotamine and opioids for more than 10 times a month. It's too much. Stop the medication. Although stopping the medication will not stop the headache, but you need to train your brain and get it off the drugs. What are the clinical features of cluster headache? At least 5 attacks are needed that meet the following criteria. It is sudden, severe, unilateral, last 15 to 180 minutes and it has a circadian and circumannal pattern, means it occurs on the same time of the day and the same time of the year. Plus your eye is sweating, means your eye is crying, there is a red eye, your nose is crying, ptosis, meiosis, edema of the eyelid and the face, sweating of the forehead and the face. Might look like an allergy. In fact, if you're having this headache in March like me, it might look like a allergic reaction. So it is a sudden onset, severe conjunctival like redness, tearing, nose rhinorrhea, headache, sweating type of thing occurring at the same time of the day and the same time of the year, lasting about 15 to 180 minutes, sudden and unilateral, severe. Treatment is your oxygen and subcutaneous sumatriptan. So your cluster people need a pass for getting oxygen in the ED at least. Give this woman oxygen. She needs it. What is the classical triad of meningitis? So it is fever. No fever. It is actually your headache plus neck stiffness plus altered mental status. So yeah, Tintinelli says that we do have altered mental status in meningitis. So the presence of fever is associated with neck stiffness, altered status. It's not headache, I'm sorry. It's fever plus neck stiffness plus altered mental status. The presence of fever with neck stiffness and altered mental status. Fever, neck stiffness and altered mental status. फना कह सकते हो इसे. Is a classical triad of meningitis present in 95% of patients. And some patients have headache as well. Classical triad plus headache. How do you choose the right imaging modality based upon the money that you have, but you can't write an exam? So you will use NCCT to see blood. NCCT is there to see blood, like trauma, thunderclap headache, you want to see bleed. New headache plus focal neurological deficit or papilledema, again you want to see blood, whether the patient is having hemorrhage or not, so we can lyse the patient or not. And chronic headache plus change in clinical features means the patient has developed a new bleed. Maybe he was on anticoagulants or DAPT and now he has developed a bleed. So all the situation we will use CT. When we will use MRI without contrast to see the parenchyma and inflammation, to see the abscess, to see the soft tissue, nerves, all these things we will use MRI. MR angiography is useful in detecting arterial disease like arterial stenosis, congenital abnormalities, dissection, CNS vasculitis, and should be considered in any case where there may be arterial pathology underlying the patient's symptoms. Many a times MRI is not feasible, they also know that. The cumulative evidence suggests that in patients with normal sensorium, no focal deficit, and without a history of immunosuppression, it is safe to proceed with LP without imaging prior to the procedure. So use this line. Again, repeat. The cumulative evidence suggests that in patient with first normal sensorium, no focal neurological deficit, without a history of immunosuppression, it is safe to proceed with LP without imaging prior to procedure. So, normal neurological no neurological deficit, normal sensorium, and no history of immunosuppression, you can do LP without an imaging, without NCCT prior to the procedure. There are certain special causes of headache. First is your meningitis. So meningitis is fever plus altered sensorium plus neck stiffness. Meningitis is due to meningeal infection and inflammation, while encephalitis is infection and inflammation of the underlying brain parenchyma. The combination of headache, fever, and neck stiffness is present in 44% cases of meningitis, although 99% of patients have at least one of these symptoms. The source can be viral, bacterial, and less commonly a fungal or parasitic. And same etiologies for encephalitis. In fact, the treatment is also the same for meningitis and encephalitis, so there is no point actually in differentiating between the two. Just know it. Know the difference. With similar etiologies, although viral cases are more common in encephalitis, have a high index of meningitis suspicion in people who are immunocompromised like HIV, cancer, chemotherapy, chronic steroids patient, and more insidious type of meningitis like cryptococcal meningitis may be there. An LP is indicated. If the LP is delayed, like CT है, कराना है, coagulopathy है, thrombocytopenia है, patient cooperative नहीं है, और meningitis is strongly suspected और आप LP नहीं कर पा रहे हो, तो you can give antibiotics without LP also. For many patients who are awake and alert without evidence of papilledema or any focal deficit, मतलब means patient awake, alert, cooperative होना चाहिए, कोई focal deficit नहीं होना चाहिए और कोई papilledema भी नहीं होना चाहिए और कोई इम्यूनोकॉम्प्रोमाइज स्टेटस भी नहीं होना चाहिए, कोई सीजर भी नहीं होना चाहिए, तो आप बिना सीटी के भी एलपी कर सकते हो. नेक्स्ट इज सब अरेकिनोइड हेमरेज. सो अक्यूट ऑनसेट सीवियर हेडेक is SAH until proven otherwise. Repeat after me. Acute onset severe headache is SAH until proven otherwise. Then there are other causes like subdural hematoma, ICH, brain tumor, cerebral venous thrombosis, posterior reversible encephalopathy. In patients with PRES can present with severe headache, vision changes, seizure and NCAF in the setting of marked BP elevation. Usually a rapidly developing hypertension in a previously normal person. It is most common in patients undergoing active treatment with immunosuppressant or modulating medication or chemo agents, and in patients of end-stage renal disease. Imaging with MRI shows evidence of symmetrical vasogenic edema in the occipital lobes of the brain. Although other brains can also be involved, treatment is just BP control and supportive care. So occipital edema, occipital vasogenic edema due to hypertension causing occipital changes like vision, seizure, NCAF, etc. Vertigo can also be there, vomiting can also be there. Vision, seizure and NCAF in marked hypertensive patient. 3. PRES. This is the American College of Rheumat ACR criteria of diagnosis of temporal arteritis. So it is mostly seen in old people more than 50 years of age, new headache with temporal artery abnormality. You may see pain in the distribution of the temporal artery, you may see fever, and you may see reddened or cord-like temporal artery, unilateral, tender, reduced pulsation of the temporal artery, and raised ESR more than 50. You can use a temporal artery biopsy. In fact, there are skip lesions as well. So you need to get at least a 2 centimeter sample of the temporal artery. But you don't need to delay treatment for this, because if you delay treatment, it is vision threatening. So you need to start steroids ASAP if you suspect a temporal arteritis. There is tenderness to palpation, decreased pulsation, vasculitis, predominance of any on the histopathy. You will see vasculitis, mononuclear cell infiltration, multinucleated giant cell. In temporal arteritis, begin treatment with prednisolone 60 mg OD to minimize morbidity from vision loss and stroke. So temporal artery blockage can cause stroke and vision loss. Consult with an ophthalmologist to determine optic nerve function and a rheumatologist. So start steroids ASAP in temporal arteritis patient, otherwise they will have a stroke and they will lose their vision, and they're very young compared, like they still have a lot of life left. Next is migraine. It is the most common not life-threatening headache in the ED, and it's very common. Happens in the young people, very notorious, very very bad, but it's still benign. Migraine is defined as a headache of a moderate to severe intensity that lasts from 4 to 72 hours and is usually unilateral, pulsatile, associated with phonophobia, and worse with physical activity. So you just want to lie down quiet in a dark room with water, drink cold water, and you're gonna sleep and you get better most of the time. Do the opposite and the headache just crimples you.